Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thank you. So this topic came up for another talk, and I thought it would be interesting to share here. So the question is, we've been doing this now for a year. We've learned a lot. We've suffered a lot. Everyone's doing great. But we're also starting to think about what the world is going to like after this. And so what lessons have we learned, and what are we going to take from this as a positive as we move forward into PrEP? But I also think that there are a lot of things that apply to HIV care as well. My disclosure is that we're going to talk about non-FDA approved ways to use PrEP. So only FTC-TDF and FTC-TAF are approved by the US, and they're only approved as daily use in some but not all populations. So just as a case to illustrate this, so, we're thinking we're at the end of the epidemic. You have a 25-year-old man who has sex with men who's been on PrEP consistently for the last 3 years. Prior to the COVID pandemic, he came in for appointments every 3 months. And during the COVID pandemic, you've seen him only once, with his last HIV testing and estimated creatinine clearance were 6 months ago. And I think many of us had a little bit more flexibility during the pandemic than we might have had before. His past medical history is significant only for secondary syphilis from a few years ago. And his social family history is that he's in an open relationship with a main partner and has had 20 condomless anal sex partners in the last year and denies any substance use. And he asks, as probably many of our patients are, it's like, I've really gotten used to not coming in so much. Do I really have to come into the clinic to see you every 3 months? So we're going to do a poll. And so what's your recommendation for him for in-person visits and laboratory testing? And there's no right answer for this. So just sort of interested in seeing how people are voting. So your recommendation is he has to come into the clinic every 3 months for regular visits and testing. Or he can come into the clinic only every 6 months for visits and testing. Or he needs to come into the clinic at least once a year, but he should get his testing done in the outpatient laboratory every 3 months. Or D, he should come into the clinic once a year, but he needs to buy home test kits every 3 months and call you to discuss those results. So I don't get to see the popcorn popping. Thanks. So a majority of folks who saying he needs to come in for yearly visits, but he needs to get lab testing every 3 months, with a few folks, about a third, voting for every 3 month visits and testing, and a smaller number of folks for every 6 months for visits and testing. And good that no one has picked my last option, and we'll talk about why that was not a right answer a little bit later. I just want to review first what the guidelines currently say, or I should say said. And these are from the 2014 guidelines, but they didn't change in the 2017 guidelines. As a reminder, we're working under CDC guidelines from 2017 that were released in 2018 with an expected update anticipated any time now to account for FTC-TAF as well as 211 dosing. But what has been in the official guidelines is that every 3 months, people are supposed to have HIV testing, at least every 6 months, serum creatinine in order to calculate an estimated creatinine clearance, at least every 6 months, a general STI screen and STI testing quarterly for people who are symptomatic. And I think many of us would do it quarterly regardless of whether people were symptomatic or not. So these were the guidelines from before the pandemic started. But we know that, thinking back perhaps more March 2020 than March, April 2021, that there was a lot of challenge with PrEP visits in particular, maybe more so with PrEP than for HIV. But a lot of these also apply for HIV care. So many of our patients didn't want to go anywhere. There were widespread restrictions and people were basically staying in their homes. There was clearly some staff unease with working in the office and seeing patients, particularly if they didn't have PPE, which several of our private providers reported they didn't have enough PPE again back in March, April. I think many clinics expanded their space in order to social distance people and staff members. PrEP changed a lot because at least at the beginning, people reduced the number of partners they were having, or at least some people reduced their partners or reduced the frequency of sex partners. There were travel restrictions, and still people are considered greater at risk if they leave the state of Washington, which is not now a problem for Canadian travel because I think we're still closed, but perhaps down in southern Washington with people crossing back and forth between Washington and Oregon and really trying to stay local, that maybe people had more problem traveling if they typically travel for their PrEP or their HIV appointments. So we made a lot of changes, and they, I think, fell into three main things. So there have been changes in how we did visits. Everybody started getting used to how to do telemedicine, telehealth. Probably we started relying on our pharmacy colleagues a little bit more. I think we were doing this even before PrEP started, but really relying on pharmacy experts to do visits and consultations about adherence at the time people were picking up their medicines. I know I reduced the frequency that I required people to come in for visits from 3 months to 6 months. There were changes in lab monitoring. So with those decreased frequency of visits came decreased frequency of testing, particularly for folks who had been doing well on their PrEP before. Laboratory-only visits, I think we started doing more of. Again, we at Madison Clinic had been starting to consider that people didn't need to come in every quarterly, that they could just get their labs done. We'd see the labs and do those quarterly refills without having to talk every 3 months about adherence and whether or not someone needed to continue, particularly folks who were stably on PrEP. And then we have talked before, and we'll talk a little bit again about home collection of HIV testing and other testing and acceptability of home self-testing where someone does their HIV test on their own. And finally, I think there were a few changes that we did in PrEP dosing and prescribing. I know I, at least at the beginning, was prescribing PrEP as 90 days rather than 30 days so that people didn't have to go into the pharmacy in March, April, and May of last year. I know we've also relied more on sending out medicines to people and people being willing to have their meds shipped to them. And then I think there's been, and again, this is sort of a little bit in parallel with 211 becoming more acceptable, being recommended by WHO and IAS, not CDC, of course, but event-based dosing, and that as providers and pharmacies, we're starting to get used to it a little bit more. So a lot of things that we've done differently. And I sort of want to go through these a little bit one at a time. And I think telemedicine is something that we did in our PrEP clinic before the pandemic, but I think many clinics are realizing that it helped in the pandemic, but also has potential as we move forward out of the pandemic. So of course, there's decreased risk for transmission of COVID and other things, maybe relevant for influenza and other respiratory illnesses as we move forward, if people stay in their homes and don't come in the clinic. Both patients and providers appreciate it because it decreases the time it takes to drive, particularly if people are coming from far away. They have to pay for parking, they have to find parking. And so it reduces time and cost, which is great for everybody, thereby increasing access, particularly as we talk about rural populations or populations that might perceive stigma in coming to a physical clinic. So those are the potential benefits. There are risks on the other side around legal issues about telemedicine. Things really changed, were changing prior to the pandemic, are changing. Insurance coverage will vary by state, but hopefully insurers will continue to cover telemedicine when people are at home. But there are risks of, do people have the technology available, both the digital literacy, both from the technology standpoint, as well as the ability to understand and use the technology and understand the risks associated with using telehealth. And then I think the big thing from my perspective is how do we ensure that people are getting the appropriate lab evaluations? So as many of you probably know, I reviewed before what we're supposed to be doing for testing. And so this was the letter that came out in May of 2020 from the CDC about how to deal with HIV testing. And so this is what CDC said, They basically said, kibosh on 6-month visits, you have to continue to do 3-month visits. We want you only to go into the lab. And then if you can't have someone go into the lab, the CDC recommended 2 additional options. One was the home specimen collection kit that was done by molecular testing labs down in Vancouver, where they are able to bill insurance. It requires an order by a provider. It gets sent to the patient. The patient has to collect their dried blood spot and other specimens, send it to molecular testing, and then the results get reported to the provider. Alternatively, the CDC recommended an oral swab-based test with the caveat that self-testing is usually not recommended for PrEP due to its lower sensitivity in detecting recent infections. And I want to go back to sort of what the CDC guidelines before the pandemic said, which is that in starting PrEP, we're supposed to document a negative antibody test in the week before initiating or reinitiating PrEP meds, additionally with an antigen antibody, formerly called a 4th-generation test, conducted by a laboratory. They then go on to say that these are taken directly from the guidelines. The required HIV testing can be accomplished by drawing blood, sending the specimen to a lab, again, for that either 4th-generation antigen antibody test or an antibody-only test, or performing a rapid point-of-care, FDA-approved fingerstick blood test, and then recommended generally backed up by a laboratory test. They explicitly say that rapid tests using oral fluid should not be used to screen for HIV, and that clinicians should not accept patient-reported test results or documented anonymous test results, which is why my answer D was not a correct test. But we can talk about it if people want to argue with me or the guidelines about it. And I'm not going to go through this for the sake of time about HIV tests and home testing options. I created this slide to sort of review, what are the window periods that we're talking about for when someone has been recently infected. And as you know, the best test is a nucleic acid test, currently available only as a laboratory-based test, but point-of-care NATs currently in development and evaluated here in this country. RNA and DNA can be detected as early as 10 days, a week and a half after infection. Next come antigen antibody tests, which according to the CDC is early as 18 days, but we know that the difference is 3 to 5 days, so I don't exactly know why the CDC has this. But generally, I say about 2 weeks after infection, and that's done on venipuncture in the lab. On fingerstick, takes an extra few days, usually about 3 weeks after someone's infected. The home collection kits generally run a antigen antibody test, so you can see as done on fingerstick, it's about the same. And then according to the package insert for the home self-collection test, the window period is 90 days. The other thing to remember is that we've seen false negatives in people who are on PrEP and confirmed HIV positive for at least 1 year in people doing oral fluid tests. So oral fluid really shouldn't be done in folks on PrEP unless it's a last resort. And I hope this is one thing that we don't carry forward. And then I just wanted to, this is the same slide that I showed a few months ago, I think when we talked about home self-collection. And the take-home point of all of the data on here is that when you send someone home to collect a dried blood spot, prick their finger, collect the dried blood spot, about 3/4 of them overall are adequate quality. So not everybody can do it. It obviously gets better if they have practice and they do more of them. But at one time here, I'm just going to send you home with this is not perfect in terms of collection. And then finally, just sort of thinking about prescribing, I just want to review, I know Ruanne talked about this last week. There was more data from CROI about 2-1-1 dosing, where people take 2, and it has to be FTC TDF. It's never been studied or not yet been studied for FTC TAF. So FTC TDF, taking 2 tablets 2 to 24 hours before sex, 1 tablet 24 hours later, and 1 tablet 24 hours after that, so 48 hours after the first one. And I think a lot of people have started, as we moved into COVID, with fewer sex acts and fewer partners, that more people were comfortable with doing this as a way of doing PrEP as well as prescribing PrEP and talking about it so that people didn't have to take their pill every day if they were having reduced exposures. So I just think that there's been a lot that we've learned, but I also want to go back to, and maybe I'll just run us back to our case to hear what people were thinking as they answered this question, or to hear what you all have taken from the COVID pandemic and really are intending to keep as we move into our post-pandemic world, and I'll say that optimistically.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.